So we're here to take a look at treating the hand. Now, in treating the hand, we're considering the wrist as well, and we're considering the radius and ulna. So you would check through all of that first. So obviously in your diagnostic process, you've gone through your normal assessment process, you've identified where there's problems, you've identified that there's a problem in the wrist or in the hand, and then you've worked through whatever you have to work through. Now, in the case of the wrist and the hand, it's very similar conceptually, or it's almost exactly the same conceptually as working on the foot. The concepts that underlie working on the foot are the concepts that underlie working anywhere. So we're looking at relational motion, we're looking at contact and control, we're looking at all of these things. Now, this won't work out perfectly as some of the things that I'm going to try to show you just because of angles are hard to see. But as we're working through the forearm and the elbow, or the forearm, so before we got to the hand, we would probably check the elbow, right? So macro identifies micro. If I identify anything with the elbow, so you want to just note that I'm using my whole hand around the elbow. I'm taking the elbow through its normal motions. If I identify something there, I would work on it, right? I will work through the forearm flexors, right? So the antebrachium, I'll work through the flexor compartment, perpendicular to soft tissue direction as is needed. Working on the extensor compartment is a little bit more difficult and a little bit more tender, primarily just because of the way the muscles lay between the radius and ulna. You're often going to have a harder time working perpendicular to soft tissue direction. You can do it if somebody's forearms are well developed here, but it's harder to do. You will also see people working and essentially going fairly pointed through this region. The distal radius and ulna, you have something here that you can do at the distal radius and ulna that you can do with the fibular head, right? So you can basically move the radius and ulna against each other, right? So I don't know if it'll show up this way, but basically contact is control, control is safety. So holding lots and also relational motion. So I can hold one, wiggle the other, I can hold the other, there you go, or I can just glide them in relation to one another. If I found some restriction, I can hold, I can go with MFR. So I have the opportunity to work on the distal radius and ulna just as if I were working on the fibular head. So in the ankle, it's harder to work at the distal end. In the knee, or in the leg below the knee, you can essentially work by gliding the fibula against a relatively still tibia. But here you can work on the radius and ulna. The wrist itself, there's varying ways to test this. You know, your deviations, right? So you can check your radial and ulnar deviation, flexion and extension, right? You find what you find. One of the things here with the wrist is that you can take a fairly shotgun approach to it. So you're looking at essentially with the wrist, often what you can do is you can just create traction, right? So you can have varying holds here. You can basically hold like you're going to arm wrestle. You can hold with two hands, right? You can do varying things. But with the wrist, one of the things you can do, if you've got a hold such as this, right? You just find your bind, you find your barrier, whatever you need to find, and then you can hold and you can create traction. So we can do this as a patient passive approach. I can just hold, or what I can do is I want you to pull your arm towards your ear, just gentle. And then I create the traction, so it's patient active traction, relax, right? I can create the traction on my own, right? Just by pulling on everything. I can create the traction by keeping the radius and ulna still and creating the traction, right? So here I can search for all my bind and barrier, create the traction that way. The thing with myself creating the traction and stabilizing the radius and ulna is that sometimes it's not as comfortable for the patient, so we want to create a hold that is effective for us, but also comfortable for the patient. So in this case, sometimes the patient active approach where you hold on to the hand and the patient pulls the arm away to create traction at the wrist, you will often get a reasonable result out of that and you'll get good traction out of it. And then obviously you go back in and you retest, right? If you're trying to move the proximal carpals in relation to the radius and ulna, this hold where you're essentially, your fingers come more or less into the carpal arch and your thumbs are on top and you work through here, right? So it basically looks like you're kind of doing articular motions, you're creating a lot of rotatory motions. When you're working in here, what I will warn you is that more often than not, the carpals end up sounding like a bag of chips. So it's not synovial cavitation. What you're really identifying is either the bones rolling, gliding on one another, or you are identifying snapping tendons, more or less. That's usually what the most likely explanation for the noise that you're going to encounter. It doesn't mean that something's back in the place that it's supposed to be. It just means you've had some noise creating activity in between the tendons and the bones, right? Or in between the tendon and a bone, or in between a bone and a bone, right? So you're working through here. You're working through the wrist as is needed. At any point that you're doing any of this, you can also add in that patient active component where you create some traction. If you need to, if you're considering how we've gone through activating forces, so compression, distraction, torsion, and shear, right? That tends to work better if you're stabilizing the radius and ulna and using the other hand on the patient's hand with respect to the wrist, right? So you create your motions as is needed. If you have to create compression, it's easier this way. You don't get compression particularly well here because there's nothing to stabilize the rest of the arm. When you get into the carpal arch itself, you get further down the carpal arch, there's a fairly easy way to deal with this, right? You basically just come in and you squeeze and flatten everything. You can add the traction in, so the patient passive traction, or you could add the patient active traction in. So pull your arm backwards, pull your arm away from me, right? And then let go. So we have those available to us again. When we get into the digits themselves, so when you get into the thumb, what I will often do is I'll take a hold where I have the patient's hand right against me. I'll stabilize the hand itself, and I'll glide the thumb against the relatively still hand. In whatever way that I need to, I can create my compression, distraction, my shear, my torsion. Torsion doesn't often do a ton in the thumb. I can work on the soft tissues in the thenar region, right? So what you'll see often is more or less a pinch, like a pinch grip, and then I can work perpendicular to the fiber direction, right? So with a push-pull there, or not perfectly perpendicular to the fiber direction, but somewhat perpendicular to the fiber direction. So again, I can work on the soft tissues, I can work on the bony articulation, and then I can go joint by joint, right? So I stabilize the proximal joint, and I work on the distal joint in whichever way I need to. And I can do the same thing with the fingers, right? So I can create traction, compression, right? I can move essentially joint by joint, but what I need to do is stabilize, and then I can work through all of those things. Usually my hand I wouldn't be holding in this way, but you can also essentially move the metacarpals against each other, right? So you stabilize and glide. You stabilize and glide. Stabilize and glide, and they will move in relation to one another. So if you have reason to think that the person's hand is not moving as effectively as it could, you can work through all of these things. The primary concept that seems to be most at play, or the two primary concepts, seem to be contact is control as well as relational motion. So one thing stays still and one thing moves in relation to it, or two things move in relation to one another at the same time. So it's a lot of information and motion essentially thrown out at one time, but because it's a video, you can pause, rewind. You've already seen all these concepts before. This is just another way to show it to you in the wrist and the hand, right? So again, contact is control, control is safety, relational motion, and then also you want to consider your activating forces. So with activating forces, you want to be organized and go in the same, essentially through the same algorithm or the same pattern each time. I tend to say compression, distraction, torsion, and shear in that order because it allows me to keep it organized. It doesn't mean that's the only order you can do it in. The basic idea is if you find one that works, you use that one. If you find one or more that works, that is another way to describe the concept of stacking. So stacking is finding barriers in one or more plane of motion that work together, or one or more activating forces. So compression, distraction, torsion, and shear all actually seem to, depending on the joint, map well to specific planes of motion. So again, your activating forces, be organized with them, and when you find one that works, when you've tested all three, you use that one. If you find one or more that work, then you use them, and then you could use that, or you could also call that stacking.